There's one really good way to understand hormonal axes and the endocrine system, and that's by looking at what happens when pieces, parts, organs, hormones don't function correctly in the system. And this is basically the idea behind different diseases. So I want to take a look at just a few diseases that are mentioned in your book and describe them for you. We're going to talk about a couple of these in class as well. And let's start with the anterior pituitary. Now, the anterior pituitary, you'll remember, secretes all kinds of different hormones, everything from prolactin and adrenal corticotropic hormone to things like thyroid stimulating hormone, etc. So you can imagine that if the anterior pituitary were damaged or if it became cancerous, that could significantly impact multiple types of hormones that are secreted in the body. I'll give you just a couple of examples of this. Let's take a look at what might happen if we have hyposecretion, meaning too little being secreted from the anterior pituitary. Maybe this happens because of some sort of physical trauma that damages the anterior pituitary. Maybe it happens because a person's born with some defect in their anterior pituitary. So if we get hyposecretion of the anterior pituitary, one of the most profound ways in which this affects the individual is that my amounts of growth hormone decrease or are eliminated. You can imagine if I'm a child, okay, so we're talking about juveniles here, and I don't have the ability to manufacture proper amounts of growth hormone, I'm going to not be able to grow properly. My epiphyseal plates, those little plates of cartilage between the diaphysis and the epiphysis or end of the bone, is not going to be able to lengthen during puberty, for example, because those chondroblasts are stimulated by growth hormone to divide and then eventually get converted into osteocytes. So the problem here with juveniles, if they have hyposecretion, is that they are unable to grow in height, and they have a condition called pituitary dwarfism. This picture here shows you an individual with pituitary dwarfism. This is only one type of dwarfism. There are other types. This particular type of dwarfism results in the individual having perfect body proportions just on a smaller scale. So the arms are in proportion to the legs and the head is in proportion to the torso, etc. There's another type of dwarfism called achondroplasia that does not relate to problems with growth hormone, but rather with how the cells that are in the epiphyseal plate respond to growth hormone. And those individuals, their head and their torso grows to normal adult size, but all their long bones cannot lengthen, and so they are a disproportionate dwarf. Their arms and legs are shorter than they should be, but the torso and head grow to full size. That's a different kind of dwarfism. Now, on the other end of the spectrum, what if a child has hypersecretion of the anterior pituitary? They're making too much, for example, growth hormone. Well, in that case, we're going to have a condition called gigantism. And gigantism results from overstimulation of the epiphyseal plates in the long bones. So they just keep adding length and adding length and adding length, and you get an individual who is proportionately correct, but on a much taller scale than we would see. So, for example, this individual here who's over 7 feet tall is somebody who has the condition gigantism. I want to emphasize gigantism only occurs if you have over-secretion of growth hormone during before the end of puberty while your epiphyseal plates are still active. If you're an adult and you've already stopped growing and your epiphyseal plates have fused into epiphyseal lines, then over-secretion of growth hormone is not going to cause gigantism because you've already stopped growing. But what it will do is growth hormone not only stimulates bones to lengthen, it also stimulates soft tissues like connective tissue, like cartilage, to continue to grow. And this produces over time a condition called acromegaly. This woman down here is an example of a patient with acromegaly. You can see when she was a little girl that she had normal facial proportions, and she still looks fairly normal proportions at age 16, but you can see by age 33 the cartilage in her nose and the soft tissue in her face have begun to be disproportionately larger than the other features of her bone features. And so by the time she is in her 50s, you can see the connective tissue in places like her hands and her face have thickened or grown quite significantly. This is called acromegaly. Now, individuals, when they're juveniles, not only get gigantism, they also get acromegaly because they do have connective tissue. But in adults, if we have hypersecretion, you cannot get gigantism. You can only get acromegaly. What if we looked at the posterior pituitary? Now, and by the way, on the anterior pituitary, I only focus on one hormone that the anterior pituitary releases, growth hormone. Remember, there's lots of other diseases that can occur if other hormones are either hyper or hyposecreted. Anyhow, let's look at one condition from the posterior pituitary to give you an example. Remember, the posterior pituitary only secretes two hormones, and those are antidiuretic hormone, and the other one is oxytocin. So let's look at what happens if I have loss of secretion of antidiuretic hormone. So this would be hyposecretion. If I get hyposecretion of ADH, the purpose of ADH, or antidiuretic hormone, remember, is to tell the kidneys to retain water so that we don't become dehydrated. You can imagine that if a person loses their ability to manufacture antidiuretic hormone, they're going to lose fluid very readily, and they're going to have copious amounts of urine. They're going to have lots and lots of urine being produced. That urine is going to be very dilute. It's going to be made up almost exclusively of water and very little solutes, very little nitrogenous waste products, and very little salts, etc. This condition is called diabetes insipidus. Insipidus means tasteless, having no taste to it. Diabetes means to run through. So this is literally urine that has no taste to it. Later when we get to talking about diabetes, I'll go more into this idea of what diabetes means and what that has to do with being able to taste or not taste. So this is hyposecretion of the posterior pituitary's ADH that it secretes. Let's move on and talk about the thyroid. Remember, the thyroid is a gland that's situated, kind of sits wrapped around your trachea near your voice box. And the role of the thyroid is to secrete a couple different hormones, one of which is thyroid hormone, obviously, and that's implicated in metabolic activity in the body. And the other hormone that the thyroid secretes that we're not going to talk about is calcitonin. You learned about that in Bio 201. Calcitonin is what stimulates the storage of calcium in places such as the bones. Now, when I have problems with thyroid hormone in particular, I can develop a number of different conditions, one of which is goiter. So let's look at what goiter is and how it can arise. A goiter is simply an enlargement of the thyroid gland, usually due to some sort of overstimulation. And that overstimulation can happen for a number of different reasons. And in order to fully explain this to you, I have to remind you about the axis here between the hypothalamus, the anterior pituitary, and the thyroid gland. So the hypothalamus, you'll remember, secretes thyrotropin-releasing hormone, causes the anterior pituitary to release thyroid-stimulating hormone, and as a result, the thyroid gland itself releases thyroid hormone. And that thyroid hormone serves as a negative feedback to both the hypothalamus and the anterior pituitary. In other words, once I've secreted thyroid hormone, we send a signal back to the hypothalamus and anterior pituitary saying, hey, we got the message. We did follow the instructions and secrete thyroid hormone, so you can stop releasing TRH and TSH because we've done our job. So now imagine, if you will, somebody loses their ability to make functional thyroid hormone. Maybe it's because they are not getting sufficient iodine in their diet. Remember, iodine is a necessary component for the manufacture of thyroid hormone. Well, then they will develop a condition called endemic goiter. And in endemic goiter, because of this deficiency of iodine, I'm not making functional thyroid hormone. And so the hypothalamus and the anterior pituitary continue to secrete more and more TRH and TSH in an effort to stimulate the thyroid gland. And the thyroid gland responds by getting larger and larger and larger, but because there's no iodine, it cannot make functional thyroid hormone, even though there's plenty of functional thyroid cells ready to go to make that. That's called endemic goiter. Again, relates to the fact that the diet the person is eating does not support proper thyroid hormone manufacture. Okay, now what about if instead, get that out of the way there, we have another problem. Let's say that the immune system starts making antibodies that look a lot like TSH. And this happens in some people. This is a type of autoimmune disease. The person's immune system starts to do something funky. It starts to make antibodies that mimic the look of TSH. So the TSH lookalikes begin to also stimulate the thyroid. So in this case, we're getting the thyroid gland getting overstimulated, and it can produce functional thyroid hormone. So we get a double whammy effect here. Not only do I get a goiter, an increase in size of the thyroid, but I also get a hugely abnormal, large number of thyroid hormone. And so this individual is going to have their metabolic rate skyrocket. They're going to have a really hard time keeping on weight. They're going to be hungry all the time. They're going to be very sleepless. They might have an increased heart rate. They're definitely going to have an increased basal metabolic rate. And they oftentimes will develop a condition called exophthalmos. Right here. Exophthalmos is this condition where you see this bulging of the eyes. Okay. By comparison, if we go back to endemic goiter, remember that was a problem where we were not making any thyroid hormones. So this person would have the opposite problem in terms of metabolic rate. Their metabolic rate would be really low. They'd probably put on weight really easily. They'd be sluggish. They'd be really cold to the touch. Their heart rate might be slower. They might exemplify signs of depression. Okay, so even though in both cases you have this goiter appearing, you can see that the other symptoms are very different because the underlying cause is different. One other thing here I'll mention really quick, and that's this picture right here, which is cretin. Well, it used to be called cretinism. Now it's called congenital hypothyroidism. If a child is born with low or no thyroid hormone produced, it impacts the ability of neurons, for example, to develop properly, and you can have a number of very serious mental retardation issues and developmental issues as a result of that. That's called congenital hypothyroidism, and this baby unfortunately has that condition. Okay, let's move on to the adrenal glands very briefly. Now you'll remember the adrenal glands have two parts, the medulla and the cortex. Let's focus on the cortex on this slide, and then we'll go on and talk a little bit about, if we have time, we'll do the medulla. Okay, so in the cortex, you can either have hypersecretion of adrenal cortical hormones, or you can have hyposecretion. Let's focus first on hypersecretion. So imagine, if you will, a person has hypersecretion. That may occur either because the adrenal cortex itself has perhaps developed a cancerous tumor, so there's more and more cells being produced and they're producing hormone, or maybe it's because there's some sort of problem in the anterior pituitary and we're getting too much ACTH being manufactured. Either way, the end result is I get elevated levels of all the different types of adrenal cortex hormones we're used to seeing, things like corticosteroids, glucocorticoids, aldosterone, etc. And so some of the conditions that can occur because of this include a moon shape appearance to the face. They call this moon face. You can get a buffalo hump on the back of the neck, kind of looks like a buffalo hump. Lots of edema throughout the body. You can get muscular weakness and lots of hyperglycemia. Now, the hyperglycemia ought to make good sense to you, glycemia, because if I'm overproducing glucocorticoids, those glucocorticoids are there to induce the release of stored sugars. So we're getting too much sugar being released, and as a result, we get this suite of conditions that includes hyperglycemia, etc. Altogether, when I have hypersecretion like this is called Cushing syndrome. Here's a lady that developed Cushing syndromes. Here's what she looked like beforehand. Here's what she looked like afterwards. And you can see she does have quite a bit of edema or puffiness to her face because of this hypersecretion. Okay, what about Addison disease? Well, Addison disease is at the opposite end of the spectrum. This is when I have a problem of hyposecretion. I'm not secreting enough aldosterone. I'm not secreting enough cortisol and other glucocorticoids. So now I have a problem with too little blood sugar. I'm probably going to have hypoglycemia. Because I'm not making sufficient amounts of aldosterone, this can be a really dangerous situation because remember, aldosterone tells the kidneys to retain sodium, and where sodium goes, water follows. So if I do not make enough aldosterone, the kidneys do not hold on to sodium, and we lose lots of water in the urine. And so electrolyte imbalances can become a real issue, as can dehydration. President Kennedy had this condition, this Addison's disease, and it's a result of a very odd autoimmune disorder. In other words, this is a problem with the immune system that induces this condition. And we're not going to go into the details of how it happens, but what it does do is it induces too much ACTH being secreted. One of the odd things is ACTH not only stimulates the adrenal cortex to release hormones, it also stimulates melanocytes. And you'll remember from 201, melanocytes are those cells in the epidermis that manufacture melanin. Melanin is the pigment that gives your skin a tannish color when you are out in the sun. And so what was really interesting about JFK was that everybody thought, oh, he looks so youthful. He always looks so tan and healthy. The reason he looked tan is because he had too much ACTH production, and that was stimulating melanocytes to produce excess melanin. He was actually very, very ill, but he always looked really tan and healthy. Sort of an ironic twist. Now, another feature that relates to the adrenal glands relates to the adrenal medulla. And the one thing I want to talk about with the adrenal medulla is its role in the stress response. Remember, the adrenal medulla is primarily responsible for secreting epinephrine and norepinephrine. And when we have any kind of a stressful situation, let's say you're working at a job and the boss yells at you, or you have to take a test in class and you're really nervous about it, or whatever it might be, there's a sort of a standardized set of responses that your body will have to stress. And the first part of the stress response is called the alarm reaction. This is the acute phase, right when you have the actual stressful event occur. And that induces the whole fight or flight response. The sympathetic nervous system gets involved. It induces the adrenal medulla to release norepinephrine and epinephrine. And we also get the release of cortisol and other types of glucocorticoids. And this helps to initiate glycogenolysis. Glycogenolysis, tear the word apart. You can see it means to split apart. That's what lysis means. And glycogen, you remember, are those long chains of sugar stored in the liver. So we're literally splitting apart stored sugar and releasing it into the blood to elevate blood sugar levels so that we can fuel things like skeletal muscle tissue and the brain and the heart during this fight or flight response. That's the alarm reaction. That's where you get the adrenaline rush you feel, where your heart rate goes up, etc. Now, a lot of times we have a stressful situation, and within a matter of minutes, the situation resolves, the test is over, the boss stops yelling at you, whatever it is, and we go back to a state of normal homeostasis. But if the stressful situation continues, like let's say you live with a roommate and you're fighting constantly with your roommate. Well, you live with your roommate. You're constantly being exposed to that stressful situation. Well, then you're going to move on to this next stage called the stage of resistance. And here, if the stress continues, your glycogen levels in your liver are going to be depleted. And at this point, we're going to now have cortisol stimulating the production of new sugar. We still want to keep blood sugar levels elevated because presumably there's still a stressful situation going on. But now, because I can't rely on glycogen stores in the liver anymore, I've got to come up with making glucose some other way. And I do this through a process called gluconeogenesis. Genesis means to create. Neo means new. Gluco relates to sugar. So literally, we are manufacturing new sugar molecules, and we do that principally by relying on stores of lipids, our fat stores. We can also eventually rely on amino acids if fat stores are depleted. The problem with long-term exposure of the body to cortisol is that it suppresses the immune system, as I talked about before. So when you get into this stage of resistance, it's not uncommon to see people get ill very easily because the elevated cortisol levels are depleting the immune system, or are suppressing the immune system, I should say. Now, in really bad situations, some people, the stress continues for so long that they continue to the final stage of the stress response called the stage of exhaustion. This usually really only happens in cases of, let's say, somebody's starving. Okay, they're under starvation conditions for a couple of weeks. Then we get into the stage of exhaustion where we've eliminated all of the lipid reserves for making sugar, and now we have to go and start stealing amino acids from skeletal muscle and other muscle in the body in order to continue making new sugars. Obviously, at this point, if something isn't done to correct the situation, the patient will go into a rapid decline. They'll experience kidney failure. They'll usually have really severe opportunistic infections because of the suppressed immune system, and they eventually will die. Okay, the last thing I want to talk about are a couple of disorders that relate to the pancreas. The pancreas, you'll remember, has both endocrine and exocrine duties. We're focusing on the endocrine duties, so the release of things like insulin and glucagon are the two principal things. And the first one I want to talk about is what happens if we have too much insulin being released from the pancreas. And this can happen maybe because a person develops a tumor in the pancreas, or maybe a diabetic injects himself with too much insulin accidentally. So with insulin, remember, the job of insulin is to cause cells in the body to grab sugar out of the blood and pull it out of the blood and store it and use it. So what happens is you get hypoglycemia immediately. That means that you have too little sugar in the blood. This is a big problem for the brain because the brain relies on blood sugar levels in order to sustain itself. If sugar levels in the blood drop, the person can very quickly start experiencing things like weakness, and they can also start to get mental confusion. They can even go so far as to have symptoms of anxiety, and eventually they can go into what's called insulin shock, where if their brain is deprived of glucose for too long, they slip into a coma. They might have convulsions or unconsciousness and disorientation, and they can even die from this. Now, when I have hypoglycemia, that triggers a number of side events, things like the secretion of epinephrine and other kinds of things like glucagon. And this all contributes to the feelings almost of an adrenaline rush. So oftentimes it's associated with hypoglycemia, that feeling of an adrenaline rush. Now, the more important condition I want to talk about with relationship to the pancreas is diabetes, and specifically diabetes mellitus. This is different from diabetes insipidus, which we talked about earlier. Diabetes mellitus got its name because back at the turn of the 19th century, the only means by which you could identify if a person had diabetes mellitus was to actually have the physician taste the patient's urine. And if the urine tasted sweet, that meant sugar was in the urine, which means sugar levels were too high in the blood and insulin was not functioning properly. So be glad you weren't a physician in the 1900s. You would have had to taste the patient's urine. Mellitus literally means sweet tasting. So this is sweet tasting urine, as opposed to diabetes insipidus. Remember I said that was tasteless urine that was so dilute with water you couldn't taste anything at all. Now, in diabetes mellitus, there are two main types, type 1 and type 2. And those two types result from two different underlying causes. Type 1 results from the loss of insulin production. We lose the beta cells. Okay, the beta cells are destroyed, and as a result, we cannot make functional insulin, and this causes us to have really high levels of sugar in the blood. It also leads to three classic signs, or the three P's of diabetes: polyuria, If I'm making a lot of sugar, if I have a lot of sugar in the blood and I can't get it out of the blood, it starts to get cleared out by the kidneys in the forming urine. And where the sugar goes, water will follow, so the person will start to be producing copious amounts of urine. This is called polyuria, too much urine. If they're losing lots of fluid in urine, then they're going to be really thirsty. So that is a second condition, polydipsia. Dipsia relates to thirst, so they have many thirsts or a lot of thirst. And the last is polyphagia. Remember, the job of insulin is to permit cells to grab onto sugar in the blood and to utilize it. If no insulin is present, then those body cells are not getting any sign that they have permission to use the sugar in the blood. And as a result, they literally are starving, even though there's plenty of sugar available. That starving signal from the cells is sent to the brain, and the brain responds by telling you to eat more. That's polyphagia, many hungers. Of course, you can eat as much as you want, but unless you have insulin, you're going to have no way of getting that sugar that you consume eventually into your body cells. Now, type 2 diabetes is a different type in that this results from the insulin no longer being effective. And that's usually because of some sort of interference. For example, adipose tissue, and I'll talk about this on the next slide, can interfere with insulin. So the heavier you get, the more adipose tissue you have, the more likely that that adipose tissue is going to start producing a hormone that interferes with insulin. When you test a patient for diabetes, usually the classic features you'll see in lab tests that tip you off are hyperglycemia, meaning really high blood sugar levels, glucosuria, which means the presence of sugar in the urine. In a normal, healthy person, there should be no glucose in the urine at all. And ketonuria, this means presence of ketones in the blood, and that is a result of the breakdown of lipids. When the body is starving, it can't utilize sugars. Oftentimes it will go to lipid stores and try to use lipids to make new sugar groups. Of course, that's a response to starvation. The problem is, again, if I don't have insulin, I can make sugar from anything I want, and I still won't be able to utilize that sugar without the permission of insulin first. So here on this next slide, let me just summarize for you. We talked about type 1 diabetes. This is also called insulin-dependent diabetes, meaning that I'm totally dependent on external sources of insulin because my beta cells have been destroyed. This is an autoimmune disease, meaning it's the person's own immune system that destroys those beta cells. Why that happens is something that's up for debate among researchers. It's also called juvenile diabetes because usually if you're going to get type 1 diabetes, it develops by the time you're about 12 years old or so. And it only accounts for roughly 1 in 10 cases of diabetes mellitus. The vast majority of cases of diabetes mellitus, the other 90%, are type 2, or what we call non-insulin dependent diabetes mellitus. This is non-insulin dependence because my beta cells function properly, I make insulin just fine, but my adipocytes in my fat tissue are secreting a hormone called resistin. And resistin literally interferes with insulin's ability to signal target cells to take up sugar. And so we get what's called insulin resistance. My receptor cells are resistant to the signal of what insulin is telling it to do. Okay? We probably also get a downregulation in the total number of insulin receptors on cells with time. And we know that there's a hereditary component to developing type 2 diabetes. If you have a relative with it, you are at greater likelihood of getting it. It normally has an onset in adulthood because it takes years and years and years to accumulate enough adipose tissue to produce enough resistin to develop diabetes type 2. Obesity is a big risk factor. What's interesting about type 2, you can actually reverse type 2. You can eliminate the problems of type 2 diabetes with weight loss because you're eliminating the adipocytes that are making that. Well, you're not eliminating them. You're reducing the size of their stores of adipose lipids, and therefore they also reduce their output of resistin. This is also called adult onset diabetes mellitus, although type 2 is being seen more and more frequently in young kids because they're getting fat at a much earlier age than they used to. Now, the one last thing I want to talk about is how we can treat diabetes mellitus, either type 1 or type 2. We all know diet is really critical for controlling sugar intake, but exercise is equally as important, and I want to explain why that is. To do that, I need to tell you how insulin first interacts with the cell. Here's a cell down here, and here's a bunch of glucose outside of the cell. Now, when glucose is present outside of the cell and insulin is released, that insulin binds to its receptor. And that insulin receptor then, because it's a protein-based hormone, it cannot enter the cell directly, but it, via a secondary messenger system, signals a secretory vessel that's inside of the cell to merge with the surface of the cell. And when it does that, it brings along with it these guys right here. These are called GLUT4 transporter proteins. And they get installed on the surface of the plasma membrane here. And once they do, they are what allows glucose molecules into the cell. Now, once insulin releases from that receptor, then these GLUT4 transporters get collected back up and installed back inside the cell until the next time insulin gives them permission to come to the surface again. Why am I telling you this? Well, because GLUT4 transporters are what we find in places like adipose tissue, skeletal muscle tissue, cardiac muscle tissue, etc. There are other types of GLUT proteins like GLUT1, GLUT2, GLUT3, GLUT4. I'm going to only talk about GLUT3 real quick. GLUT3 transporter proteins are found in places like neurons. And rather than being stored inside the cell and only brought to the plasma membrane surface when insulin tells them to, type 3 GLUT transporter proteins actually are always on the plasma membrane surface. And that's important for neurons because they need to have a constant, steady access to glucose. We don't want to wait for insulin to give the brain permission to get the glucose it needs. By comparison, GLUT4 transport proteins, as I said, are insulin dependent. We have to have insulin present in order for those GLUT transport proteins to be installed and for that tissue then to take glucose into the cell. There's an exception though. When you are exercising, skeletal muscle tissues can automatically move GLUT4 transport proteins to the surface of the cell. So when you are exercising, you do not need to have insulin's permission for skeletal muscle tissue to use glucose. And so basically exercising is a natural way for diabetics to deplete or diminish levels of sugar in the blood, and you don't even have to involve insulin in the process. And this is why exercise is so critically important for all diabetics as a regular routine thing that they do every single day.